we're absolutely delighted Dr. Jennifer Reed can join us today. And she's a full-time scientist and the director of the Exercise Physiology and Cardiovascular Health Lab here at the University of Ottawa Heart Institute. And I thought this is a perfect topic, for the new year. Many of us have made resolutions that we're going to exercise more, and Jennifer will give you the tips how to do that and stick this through for the next 365 days. And she's also associate professor of School of Epidemiology and Public Health in the Faculty of Medicine here at the University of Ottawa. And she's a registered kinesiologist with the College of Kinesiologists in Ontario. And Jennifer has been a superbly successful researcher. She's been passionate in terms of the role of exercise in preventing and managing cardiovascular disease in various domains, and with a particular focus in terms of women's heart health. And also she has a very interesting program, and I think it's gathering a lot of attention, and that is the role of exercise in the prevention and management of patients with atrial fibrillation, which of course is the commonest heart rhythm disorder in the world. And she's developing novel exercise training strategies for these conditions, and re-examining and challenging the traditional approaches for this. And this is where I learned the HIT versus MICE and all these different terms that you hear about. Dr. Reed will award more than $6 million in terms of peer reviewed research funding, and she's still pretty young, I think you will see. And she's published more than 90 peer-reviewed manuscripts and more than 70 invited presentations around the world. And she's really contributed a lot in terms of our understanding of exercise recommendations. I know her work has been quoted near and far by her colleagues and many others, in the field. So this is really actually very exciting. And so today she will present for us on the topic of stepping up cardiovascular care for atrial fibrillation and women's heart health. Jennifer.
Everyone. So thank you, first and foremost for having me here to start off the new year. It's truly an honor. And I'd like to add to the intro that this is actually my 10-year anniversary at the Heart Institute. I started, I know, I was actually, yes, very much younger. But I started on January 2nd, 10 years ago. And while I was preparing this talk, I'm reminded that I actually kept my parking ticket from my interview on November 28th with Dr. Andrew Pipe and other colleagues who have become really friends since then. And so I've kept that parking ticket because the minute I met Dr. Andrew Pipe, I knew that this was the place that I could likely achieve great things. And so over the past decade, I have strived very hard to grow a program from an N of 1 to this fabulous group that I get to work with every single day and the colleagues that I get to work with. So we often do our thanks at the end of the presentation, which I will absolutely do. But I first and foremost wanted to kick it off with, it's the new year and it's my 10-year anniversary of being at the Heart Institute. So I graciously thank you for having me to start off the research rounds this year. Okay, so now that all the pleasantries are taken care of, we're going to get right to the heart of physical activity and exercise. Little disappointed, not many of you are wearing your exercise gear for today's presentation. I'll give you a pass for this particular day, but note, I will find you in the hallways or elsewhere. So the focus for today is twofold. One is to discuss my particular research focus on atrial fibrillation, and the second being women's heart health. And actually both of these become intertwined, as you'll see with the evolution of my program and my training in women's heart health. This audience likely doesn't need a review of what constitutes atrial fibrillation. As you likely well know, it is characterized by a fast and irregular heart rate. And atrial fibrillation is a condition that affects many across Canada and the globe. This particular figure from a publication several years ago by Dr. Jason Andrade, who actually led the recent updates of the clinical guidelines for the management of atrial fibrillation, published this document in Circulation Research, likely one of the most well-used figures when discussing atrial fibrillation prevalence. And from a pooled analysis of a number of trials, this figure shows the average AF prevalence across age groups. And what you can see is that the prevalence increases with age. And it's particularly higher in those over the age of 80 years. Now, you may be wondering, how does this apply globally? How does this apply to Canada? And so if we look across the globe, we see that about 37 million individuals suffer or live with atrial fibrillation, and about 450,000. These statistics are from about 2 years ago now. And given that it is a growing epidemic, we expect these values to be slightly higher than those quoted here today. But about 450,000 Canadians are living with atrial fibrillation from coast to coast. At patients, we know often that they experience these disabling and very rather unpleasant symptoms. And these include exercise intolerance, and the focus for much of my research program, diaphoresis, palpitations, of course, anxiety, dizziness, chest discomfort, acute or chronic heart failure, fatigue, depression, dyspnea. And collectively, these disabling symptoms, bothersome symptoms, result in substantially reduced quality of life. Atrial fibrillation is also associated with heightened risk of morbidity and mortality and risk of stroke. The clinical management of atrial fibrillation is largely focused on improving the quality of life and reducing the symptoms of patients who experience this severe medical condition. We often apply rate and rhythm control medications to manage this irregular and fast heart rate. Also, anticoagulation medication is part and parcel of the treatment for patients with AFib, given their heightened risk of stroke. And then a number of procedures are also used to combat this medical condition, including catheter ablation and cardioversion. Despite these available treatments, there are studies that report that approximately 80% of patients with atrial fibrillation suffer ongoing symptoms, despite what is medically available for them. And that's really been a large focus, and the thrust of my particular research program is what more can we do for patients with atrial fibrillation? How can we apply physical activity and structured exercise training in the management and prevention of this patient population? Since 2013, there has been growing literature examining the role of exercise training being structured in physical activity in the prevention and management of atrial fibrillation, and specifically to address the poor physical and mental health of these patients. And so I'm just going to walk you along very briefly some of the systematic reviews and also a Cochrane review that have focused on the effects, chronic effects of exercise training. And if we look across all of these studies and collectively at the results, we can see that regular exercise training from approximately 8 weeks to 12 weeks or even greater has resulted in significantly greater improvements in peak aerobic power, largely known as cardiorespiratory fitness, functional capacity, often measured by a 6-minute walk test, strength, power, activities of daily living, quality of life, cardiac function, and this is largely denoted by reductions in both resting, submaximal peak exercise heart rates, as well as improved ejection fraction and symptom burden, a great focus of the management for patients with this particular condition. A few years ago, Elliott and colleagues from Australia published this excellent review on exercise training, physical activity, and managing patients with atrial fibrillation. This was published in Circulation in 2016. And if we look across the FIT principles, the frequency, the intensity, the time, and type, what they performed fairly well was a nice summary of the short and long-term effects, but they also speculated on the mechanisms that are linked to the regular practice of physical activity. And they speculated and proposed within this excellent article that exercise is likely to reverse atrial remodeling. It's to play a role in weight loss, which has been largely and significantly associated with the development and progression of atrial fibrillation, the improvement of blood pressure control, glycemic control, reduced inflammation, and improved autonomic tone. So these are some of the mechanisms by which exercise can address the poor physical and mental health of those with atrial fibrillation. What has been a delight to see in the literature, and of course the discussions among colleagues, is that some of the guidelines for the management for patients with atrial fibrillation have recently included exercise. And this is extremely important because prior to this document that was just published in late 2020, there were no clinical guidelines really endorsing physical activity or exercise for this patient population. Those certainly new, but surprising that we are in 2020, and given the known well-established benefits of physical activity and exercise, these have not appeared in clinical guidelines for those with atrial fibrillation, but we find them elsewhere in all other cardiovascular conditions. And this is actually where my research program began. I began in cardiac prevention and rehabilitation, and I thought it was absurd, perhaps not absurd, I won't use that tone, but I did think it was absurd, that all other patients that have coronary artery disease, heart failure, even peripheral arterial disease later on, all of these patient populations that we see within our research program were recommended exercise and physical activity, but not if you were a patient with atrial fibrillation. And so that's where this began. And that was the thrust of a lot of the systematic reviews is we know the benefits of physical activity and exercise. So what are these specific benefits when applied to the atrial fibrillation literature? So if we look at the European Cardiology Society guidelines for their diagnosis and management of atrial fibrillation, and I apologize now looking at this box, it's very difficult to see from where you might be sitting, but I will read to you the exact wording, which is physical activity should be considered to help prevent AF incidents or recurrence with the exception of excessive endurance exercise, which may promote atrial fibrillation. So the European guidelines have recently recommended the incorporation of physical activity, and also recently the guidelines for the Canadian Cardiovascular Society. We have recently seen in late 2020, led by Dr. Jason Andrade, the release of guidelines for atrial fibrillation that include exercise targets for the very first time, the first around the world. And so these recommendations have a specific section focused on exercise. They recommend moderate intensity aerobic exercise at least 30 minutes a day, at least 3 to 5 days per week, a target of at least 200 minutes per week. They also recommend resistance exercise 2 to 3 days per week and flexibility exercises at least 10 minutes per day, at least 2 days per week, and those over the age of 65. Now you may think this is very specific. This is even more specific than general Canadian physical activity guidelines and even more specific than the World Health Organization guidelines. And you are right, they are quite specific. And these guidelines also include this integrated AF clinic plan where they endorse exercise physiology, which is very important to see a number of allied healthcare professionals being incorporated into these clinical guidelines. So although I was delighted to see the incorporation of these exercise targets, I could not hold myself back from writing and publishing a letter to the editor in the Canadian Journal of Cardiology, because the release of these exercise guidelines, although long called for, generated a lot of discussion around exercise professionals across the globe, because we were interested in knowing where these specific guidelines had come from, which specific studies are supporting these targets for patients with atrial fibrillation, since the actual total volume of 200 minutes per week is greater than what we see with our Canadian physical activity guidelines and with our World Health Organization guidelines, both of which have been updated recently in the last few years. So if you're interested in reading a bit more regarding these targets and some of the questions we had regarding the minutes per week and the incorporation of sex and gender, I would encourage you to read this letter. So included a summary figure of all of the research that had been conducted to date. We outlined the physical and psychosocial improvements following exercise that had been reported in the literature. These interventions were 8 to 16 plus weeks, and the volume of exercise ranged from 60 to 225 minutes. So there were surely studies that had showed clinical and significant benefits in physical and mental health that were much below the 200 threshold. And so this figure summarizes these findings, being that regular exercise was associated with improvements in cardiorespiratory fitness, functional capacity as measured by a 6-minute walk test, left ventricular ejection fraction, quality of life, and then reductions in resting heart rate and maximal heart rates, which are important for those with atrial fibrillation. Time in AF was also observed to be significantly reduced, symptom burden, and cardiovascular disease risk factors, although the results were certainly conflicting regarding the impact on cardiovascular risk factors as a whole. Shift gears a bit, and as Dr. Liu mentioned, he's learned over the years some of these new acronyms. So of course, my presentation will need to focus on HIT and MIT or mice. And so much of the research that's been done to date has focused on continuous forms of exercise. And when I indicate continuous exercise, that's your traditional exercise of 20, 30, 40, 50, 60 plus minutes in a continuous format without break, usually at a moderate to vigorous intensity. But over the years, we've seen a lot more focus on high intensity interval training because prior studies in non-cardiovascular disease populations, non-chronic disease populations have certainly showed the superiority of HIT when compared to other traditional forms of exercise. And HIT is certainly not a new concept. This dates back to the time of the ancient Greeks. This form of exercise was used to train athletes requiring high levels of fitness for track and team sport athletes. But it's more so novel to apply this in chronic conditions and those with heart disease. And so that's where the novelty and the importance comes from, is it's been shown to be a superior in terms of improving cardiorespiratory fitness and other clinical outcomes. It's also time efficient and can be done using a variety of modalities. So this concept of interval training has been applied to patients with cardiovascular disease several times in many trials over the past decade. And I will share with you a figure that you have likely seen if you've viewed any of my prior presentations, but I always like to set the stage and just give you an idea of what high intensity interval training is. And so this is one protocol of many that you'll find in the literature, but it simply shows what interval training may look like. And these can be adapted in many forms. Typically, they're 35 to 40 minutes. They begin with a warm-up. And then in this particular model, which we call the Norwegian model or the modified Norwegian model, there are 4 work periods at high intensity, usually 85 to 95% of peak heart rate, and interspersed with those work periods are low intensity exercise, usually 60 to 70% of peak heart rate. So this is a model that's been used extensively in the literature, but there are many, many other protocols that have been used and tested in those with a variety of heart disease conditions. The research over the years certainly has included some systematic reviews to consolidate and collectively evaluate the data that's been published. And so what we've seen across a number of cardiovascular populations, those with coronary artery disease and heart failure, is the superior effects of high intensity interval training versus MIT or mice. And we've seen greater improvements in VO2 peak, cardiorespiratory fitness, peak power, resting and submaximal heart rates, blood pressure, left ventricular filling speed and diastolic function or relaxation, high density lipoprotein and triglycerides, fasting glucose concentrations, mental health, including quality of life and motivation. So the list continues to build for the superiority of HIT versus MIT or other exercise programs in those with a variety of cardiovascular conditions. Landed itself in Circulation in 2016. It's I would call it a seminal publication within this area of research. And this was conducted by our Norwegian friends and colleagues, Malmo. And this particular trial was the first to investigate interval training in a group of non-permanent patients with atrial fibrillation, so non-permanent atrial fibrillation. They performed HIT training 3 days a week for 12 weeks, and they compared that to those engaging in their regular exercise training habits. They were asked not not to change their current behavior. And so what was so important about this trial was, for this to land in circulation meant it had to have a very important clinical outcome. It had to be clearly important for the larger cardiovascular population. And it showed significantly reduced time in atrial fibrillation following this aggressive form of exercise several times a week for 12 weeks. And so the exercise group experienced a 3.3 reduction in time in AF, and the control group actually experienced a mean change of an increase of 4.2% time spent in atrial fibrillation. So between these two groups, we saw a significant improvement in time spent in atrial fibrillation. And this paper has largely informed and helped to advance other areas of research. With you, after many years, we actually finished our trial looking at high intensity interval training and MIT or mice or cardiac rehab in our own patients with persistent and permanent atrial fibrillation. We focused the trial on those at the more severe end of the spectrum because these are often patients that are without other treatment options. Many of these patients with their physician have decided not to pursue other forms of treatment, including cardioversion and ablation. They will exist with medications. But given the ongoing disabling and suffering symptoms, we wanted to focus on those patients that may have the more severe symptoms, perhaps, but also had been struggling with this condition for quite some time. And so this was published just the end of this last year now, 2022. We're now into 2023. I have to remind myself that. But this was published in JAMA Network Open. And so we demonstrated that in patients with permanent and persistent atrial fibrillation, that twice weekly exercise training sessions, whether conducted on cycle ergometers with our research staff or part of our regular cardiac rehabilitation program, we demonstrated that we could conduct this trial. And so this figure, although maybe perhaps hard to see from your vantage point, this is a culmination of over 7,000 data points. And so we really wanted to ensure that this figure that was done by one of my PhD students, Salvador Emila, who combined all of the data. We collected multiple points of heart rate throughout every single exercise training session. So during the high bouts and the low bouts and the continuous bouts, multiple time points throughout the exercise sessions. And we also collected rating of perceived exertion data. And so this figure shows that we in fact were able to exercise our patients at a high intensity interval training. And of course, the patients in the MICE group or the MIT group or cardiac rehab exercise within their guidelines. You may note the large standard deviation bars. So there's quite a bit of variability within these data points. And that's probably not surprising given these patients are those with atrial fibrillation, but we collected the data nonetheless so we could report on it because heart rate is an objective measure that's typically used to assess and monitor and prescribe exercise intensity. What did we find? Well, we actually found across our co-primary outcomes, and I say co-primary outcomes with a bit of emphasis because I remember when designing this trial, meeting with Dr. George Wells and the discussion of having two co-primary outcomes for an RCT. But we wanted to ensure that quality of life, a patient-rated measure was included as a primary outcome, given this is a focus of their treatment and their ongoing symptoms. So we included quality of life as a primary outcome, and we also included functional capacity, a 6-minute walk test, which is known to be highly associated, significantly positively associated with morbidity and mortality. And so what we found and across our co-primary outcomes was no differences between the two exercise training groups. So both groups improved, but the improvements were not different between the two. So whether patients engaged in our time-efficient HIIT sessions twice a week on cycle ergometers with our team or enrolled in our cardiac rehabilitation program, they both experienced improvements, but the improvements were not different between the two groups. We did include females within these trials, and so this is a large focus actually of my PhD student Sol. Her work is largely focused on looking at sex differences in both patients presenting with atrial fibrillation to cardiac rehabilitation programs and sex differences in these exercise interventions. She will hopefully be defending by the end of the semester, so you'll have to sit tight as we wait for her to complete her very ambitious PhD projects. We certainly are not done with our evaluation of HIT in patients with atrial fibrillation. In fact, we have an ongoing RCT. And so this is my yearly plea to all of my colleagues within the arrhythmia clinic and the building that if you have patients with persistent or permanent atrial fibrillation, I would highly encourage you to refer them to the trial if we haven't already found them through our EPIC system. But this is a trial funded by CIHR. And so we have a target recruitment of 132. The trial is underway, but some of the improvements that we made in this particular trial is one, including a control group. And two, what we have done is we've moved all of the exercise training sessions to a more standardized format. So they're all done on cyclo ergometers under our advisement and care within our laboratory. And so we've taken them from out of the cardiac rehabilitation program in order to really standardize the way that we're evaluating these programs. So it's giving us a real world evaluation in our first trial that we just published, and now so in a more laboratory-based setting. And so this trial is underway, but we hopefully will have results in the next year or two to share with you. Focused on the chronic evaluation of exercise training. We actually have spent a bit of time looking at the acute responses. And it's so important for us to evaluate the acute responses very carefully. And this is what we've done in a case study published in the European Heart Journal, which made considerable waves over Twitter and other methods of social media, because this is actually one of the first trials to show the very acute responses in the form of ratings of perceived exertion, heart rate, blood pressure, and workload in patients with atrial fibrillation. And so I'm not going to take you through the details of this particular slide. There's a lot of data packed into this case study. We included 4 adult males as we had data from this a little while ago. And so we very meticulously reported on all of this data. And the reason we wanted to move ahead and publish this case series with these patients with differing, they all presented with atrial fibrillation, but different cardiovascular conditions as well, is because when a patient is sitting in front of you, they want to know what it would be like to experience a session of high intensity interval training or a session of cardiac rehab or MIT or MICE. And so this case series really well and detailed highlights what occurs when a patient engages in a HIT session. And so this meticulous data was captured in this case series. It's available open access in European Heart Journal case reports, if interested in reading. And the end of 2022 is likely not going to come to a surprise of many of you sitting in the room or listening virtually, in that if we remove the effects of exercise training, what might happen? Well, the benefits are lost. And it's a simple but important trial to conduct, because we need to demonstrate that if we remove the intervention and of course don't continue to advocate for the regular practice of physical activity and exercise training, the benefits that patients reap within these trials or other programs in their community or at the Heart Institute will be lost. And this study nicely demonstrated this in a sample of approximately 40 patients with atrial fibrillation, that when you remove a 3-month intervention, reductions in exercise duration and peak power as measured on a cyclo ergometer and quality of life was reduced when the intervention was removed. Again, not surprising, but a very important message we need to communicate to our patients, that we need to be active every day of the week if we can. And it doesn't need to be always a vigorous form of exercise. Some exercise is better than none, and more is better than some. And a message I like to convey and repeat every chance I really can. So we've spent a bit of time focused on the chronic effects of exercise training, certainly some of the acute effects and what happens when we remove the intervention, but now how physically active are patients with atrial fibrillation? And so this study, which was published a few years ago, was an international trial looking at the self-reported data of patients with atrial fibrillation, each subtype of atrial fibrillation. And what they demonstrated, not including Canadian participants, was that patients on average are certainly physically inactive. About 60% or 55% of patients with atrial fibrillation are not meeting physical activity guidelines. This is actually likely to be much higher because this uses self-report tools. And most of you will likely know that self-report tools are often associated with recall bias and social desirability. So 60% of being physically inactive likely is closer to 70 or 75% if we were to measure their physical activity levels with research-grade devices. They did importantly show that those with permanent atrial fibrillation were less physically active than the other subtypes of atrial fibrillation. And often patients with permanent atrial fibrillation are older adults who've existed with their medical condition and symptoms for quite a few years. So this set the stage for our Champlain AF study. And actually this was the brainchild of myself and some friends of mine I met at Europrevent quite a few years ago. Over 1 or 2 glasses of wine, we discussed the importance of really evaluating the lifestyle effects on patients with atrial fibrillation. And so that then became a moment to seize. And so I returned back to Canada working with my colleagues overseas, and we developed the Champlain AF study. We had received funds from Servier Canada. I had actually pitched the idea of the trial, and can you imagine, no grant was required. I sent an email outlining my idea, and a few weeks later, a representative from Servier Canada showed up with a check in hand. No press required, simply handed me the check and said, you know, we're very excited about this project. Let us know when it's published. And so I walked away with my check in hand, and then we conducted this trial. Probably the easiest money I've ever made in research. I don't know if I'll ever make that again, but we thank Servier as often as we can, because this was truly a no strings attached, show up, drop a check, and walk away. And so what we did with that is, one, I hired a phenomenal postdoctoral fellow, Dr. Kimberly Way, who relocated from Australia to come and to lead this trial. And then I found some wonderful friends and colleagues across the country. And so we embarked on the Champlain AF study. Again, we used self-reported measures given our budget and timing, but we importantly finished this trial with 619 patients with atrial fibrillation, one of the largest certainly done within any individual country. We included 66% male participants. This was largely due to we didn't have a specific recruitment plan for males or females. We recruited everyone. And so not surprising that we have a bit higher male recruitment rate, but certainly wanted to point that out here with respects to the findings. All subtypes of atrial fibrillation were included. What we found, which aligns with some of our international data, again, self-reported, was that 56% were not meeting the Canadian physical activity guidelines, and 54% did not know or were unsure of the physical activity recommendations. Physical activity data is largely non-normally distributed. It can be a difficult beast to analyze and present. And so doing right by our statistical analysis friends, we reported median data with our physical activity measures because of the non-normality. But what I can report here is the patients reported a median of 100 minutes of moderate to vigorous physical activity per week, and that they spent on average 6 hours a day. I shouldn't say average, a median of 6 hours of sitting time per day. So this was really the beginning of what has become a much larger research program. But included in this paper, we really wanted to dive beyond just assessing self-report levels of physical activity. We wanted to get to the knowledge, the values, the attitudes regarding physical activity. And so I will read this out loud in case this is a bit difficult to decipher, depending on where you're sitting. But 59% of patients reported that no, a healthcare professional had not spoken to them about engaging in physical activity. 81% reported, yes, physical activity can help manage other conditions that they may present with. 66% reported no, that they didn't think physical activity was dangerous for their atrial fibrillation, but 72% reported that they think that physical activity should be part of their management plan. So patients are indicating that it should be part of their management plan. They don't believe it's dangerous for their health, but no one has spoken to them, or a large majority have not spoken to them about physical activity for managing their atrial fibrillation. So of course, one research question snowballs into the other when you have a curious mind and a passion for research. And so we were very fortunate to receive another Canadian Institute of Health Research, CIHR, project scheme grant within the area of atrial fibrillation and physical activity. This is a multi-site population health study. My research manager, Matthias Mistura, is going to ensure that we recruit all participants on time across all of these sites. No sweat, right, Matthias? Yeah. So we have 5 sites located across Canada. We have importantly included a Quebec site and Quebec investigators. And so we will recruit just over 1,100 participants, equal recruitment of males and females. And this was a non-negotiable point for our recruitment plan with this grant. Wanted to ensure that we had at least an equal number of males and females included within this research. We have also partners in Romania and Australia. And so there has been large discussions of moving this trial international. And so we're exploring other funding opportunities for that. But what we're doing, 2 points that are different in this trial. One is we're going to use research grade accelerometers. Much of the data has been self-reported, and we need to really capture physical activity levels well in this population. 2, a subset of these patients are going to wear a wireless ECG and be monitored continuously for 7 days while wearing a research grade accelerometer. We are very interested in understanding the relationship between physical activity and the intensity of physical activity with the time in AF and the symptoms that patients may experience. And this certainly has not been done to date, but this is using more innovative novel technology and pairing it with really the need for gold standard physical activity measurement. And so we are just putting through the ethics application now. And then once we have that, we will quickly be recruiting here and then going through ethics across the other sites within Canada. So if I can quickly summarize the atrial fibrillation pieces, well, one is they experience ongoing symptoms despite available treatments and procedures. There has been growing research examining the practices of physical activity and exercise training and managing patients. We should continue to advocate regular physical activity, at least 150 minutes if we look to Canadian physical activity guidelines, or if we look to the most recent CCS guidelines of at least 200 minutes. We may need more intense or targeted programs. That is to be determined with future research, and we certainly want to be collaborative and include all of our other colleagues, especially those in exercise psychology, which may help to inform how to best advise patients to engage in exercise. From the atrial fibrillation world, as I keep an eye on time, and I'm going to move us into our focus on women and heart disease. In this room and listening online are not going to be surprised at any of these statistics that I'm going to read out loud, but I feel it's important to continue reiterating these statistics. So hopefully in the future, these numbers will change when I give a next update. And so first and foremost, heart disease is the leading cause of premature death among women in Canada. Mortality rate is about 20% for heart disease for women and girls in Canada. And more than 50% of Canadian women lack the knowledge of heart disease risk factors. Most do not know their own level of risk. Series of manuscripts published by the Canadian Women's Heart Health Alliance. This figure nicely summarizes the risk of cardiovascular disease for women over the course of their life, beginning with age of menarche and ending postmenopausal. But what you can see along the top of this figure is throughout the duration of a woman's life, traditional risk factors exist, and those that will be well known to you. And these include type 2 diabetes, hypertension, smoking, dyslipidemia. All of these traditional cardiovascular disease risk factors that you're used to seeing actually pose greater complications for women than they do for men with heart disease. That the high intensity interval training literature has looked at HIIT versus other forms of exercise across a number of cardiovascular conditions. This certainly just isn't specific to those with atrial fibrillation. And these studies, again, in those with cardiometabolic disease and heart disease, have shown improvements in cardiorespiratory fitness, blood pressure, vascular function, high density lipoprotein, and body composition. But when we look across these studies that have been conducted, we felt the importance to highlight where are the women? And so that's what we did in our letter, our perspective letter in circulation, myself and Dr. Kimberly Way, who is a former postdoc of mine, now located at Deakin University. And so we presented this perspective really to encourage the community to think about the inclusion of women in exercise training trials. And so we had two important messages that we wanted to ensure were read. One is we need to stop repeating past practices. Women continue to be under-included, underrepresented, and undertreated despite a greater understanding of the cardiovascular burdens experienced by women. And two, we need to address the knowledge gap now. The efficacy of HIIT on the physical and mental health outcomes in women with heart disease is certainly not clear and needs to be an area for further understanding. We can't simply continue with the trials exploring treatment options without including a significant portion of women. We treat males and females, men and women, and therefore the trials need to be reflective of the populations that we're treating. I had the honor of contributing to this European Heart Journal article at the end of 2021 with a group of colleagues from McMaster University. The lead or senior author, was Dr. Harriet Van Spel. And we looked at the underrepresentation of females in sports science research. And although this extends beyond, heart disease patients, we wanted to point out, and I thought it was important to share today, is that when we looked across studies from 2014 to 2020, only 34% of studies focused on exercise science included females. And so this was highlighted in this perspective in European Heart Journal. Work examining the literature, compiling our thoughts in a few of these perspective pieces, we looked to the orbit model that we use routinely in terms of trial development. And we first wanted to examine the feasibility of HIIT in women with cardiac rehab. And so this was actually a project, my first project, or one of my first that I started at the Institute years and years ago, was developing a women-only interval training program. We called it aerobic interval training. We called it Zumba. We called it many things, dance-based movement exercise. And we developed it for women, and we had a phenomenal physiotherapist that was pivotal in developing this program and leading it, which was Marilena Keast. And so she would be so pleased to see these results being presented again and again because, with such a role that she played in helping to get this set up. But we looked at the feasibility of this program. It's been running for several years now. This particular publication included over 150 patients, 33% being women. And you may say, but it's a women-only program. How do we only have 33% women? Well, over the course of the years, many men wanted to join this program. They would actually come into our program and use the track and see the women dancing to the screens with all of the technologies that they were wearing and wanted to become part of the program. And so they did. And so over time, they actually overtook, in terms of volume of patients in this program, more men than women. But that gave us an opportunity to look at sex differences within our program and meet the needs of both males and females, men and women. So we showed a low attrition rate, but more women dropped out of the program than did men. But there were no sex differences in class attendance or compliance with the exercise prescription. So they could adhere to the program. They were compliant with the program, but we did see greater dropout of men than women. And what's interesting, and when we look further into this research at the psychosocial health, is that depending if you were a male or a female or self-identify as women versus men, we actually observed differential responses in that men experienced greater reductions in anxiety of participating in our MICE or our MID or our cardiac interval training program than did women. Women experienced greater improvements in anxiety of participating in our interval training program. So the modalities of the exercise training program, whether high intensity interval training versus our standard cardiac rehab, had differential impacts on women versus men when it came to anxiety, mental health. That further and wanted to look at sex differences within cardiorespiratory fitness within high intensity interval training program at the Heart Institute, given the known strong association between cardiorespiratory fitness and morbidity and mortality. And so this publication, published the end of 2021, led by PhD student Saul Vidal-Amilla, showed that there were no significant differences, improvements in VO2 peak did not differ between the sexes. So no significant differences between males and females with regards to cardiorespiratory fitness. And we wanted to go beyond the walls of the Heart Institute, and we wanted to expand across the globe. So we reached out to all of our colleagues who had been doing work regarding interval training and those with a focus on women's heart health. And we pleaded with them through multiple emails to share any of their data that we could, so we could conduct a systematic review examining sex differences in interval training amongst males and females. And so it certainly was difficult to acquire all of this raw data, but we spent many months sending emails and reminders and providing any assistance we could to acquire the raw data from trials. So published data, but also raw unpublished data, anything that they had, so we could look at sex differences with regards to interval training. And women actually experienced significantly smaller improvements in absolute cardiorespiratory fitness after interval training than compared to men. So we did see a sex difference when it came to cardiorespiratory fitness, and a very important outcome with respect to morbidity and mortality. But what you cannot see from sitting in your seat likely or online closely is the number of males versus females. So despite our international efforts, we were only able to include about 40 women in this systematic review because of such low representation of women across all of these HIT trials in women with heart disease or cardiometabolic diseases to date. We also went beyond cardiorespiratory fitness, and we looked at body mass index and blood glucose and a number of other cardiovascular risk factors. So we did see smaller improvements in body mass index and fasting blood glucose concentrations in women than men, but we did not see any differences in the other traditional cardiovascular disease risk factors. But I want to leave you with a reminder that despite all of our efforts to acquire published and unpublished data, only 40-some women included in this systematic review. Certainly enough for a systematic review, but it just speaks to the vast underrepresentation of women in all of these trials across the globe. So it really needs to be a huge focus for work moving forward. And so I have pulled an excerpt from this particular manuscript, which I don't plan to review, but this is, I would say, almost boilerplate template in almost every publication I read. So in future studies, women should be a focus because only 19% of the patients in the study were women. Although not unusual in similar studies, this sex bias was unintended and constitutes a limitation of the generalization of the results. I'm pretty sure I could pull 15 or 16 different publications and see the same statement in the strengths and weaknesses limitations of most of these types of publications. So we need to go beyond just saying it's a bias. We only included those that were available. We have to ensure an equal number or greater than 50% women to account for the clear underrepresentation of women in existing trials. News here, and that is the end of last year, we saw the first trial of HIT and women published in JAMA Cardiology. Small subset, or a small N, I should say, just over 50 patients, but they exercised 3 days a week for 12 weeks, women only. And this did show improvements in VO2 peak, but measured as liters per minute in absolute value, not accounting for lean body mass or body composition. And this is, I feel, a limitation of this trial, although so important to see in the literature, but these women did lose weight over the course of the trial. There were changes in body composition. So if you want to truly examine or account for the confounding effects of body composition, then we do see no differences when we look at relative changes in cardiorespiratory fitness over the course of this intervention. But nonetheless, a really important trial to see. It's the first women-only trial that's been done. And at the same time, we actually were awarded funding from the Heart and Stroke Foundation of Canada during the peak of the pandemic, one of the few probably, well, we are one of the few that did receive funding from Heart and Stroke during the peak of the pandemic, but this is for our women's only exercise training trial. Because of the pandemic, it really afforded us an opportunity to move this trial in a virtual capacity. And so this trial is being done over Zoom, where we offer our exercise training sessions live with pre-recorded choreographed exercise training strategies. We have coffee houses, Q&As, all done in a virtual setting. And so we are in the midst of conducting this trial, and of course, we'll be seeking additional funding given the shortfall of heart and stroke during this particular term, but we do hope that we can continue leading this trial. When we speak to women's heart health, well, again, no surprise, it's the leading cause of premature death among women in Canada. HIT has been shown to achieve smaller or similar improvements in cardiovascular disease risk factors in adults with cardiometabolic disease and cardiovascular disease. Women continue to be underrepresented and undertreated. We really must change this. We have to stop saying that we will or that we acknowledge it. And women are not small men. We cannot treat them the same. And so we need women-specific data for women-specific solutions. I moved to the end. I was asked today to speak about some of our EDI initiatives within the lab, and I think we have a few that we can be really proud of, but one that I wanted to highlight today, and that is during the pandemic, we started a virtual international student research internship for women only in exercise science. And so we put our first call out on Twitter about 3 years ago now, and we had applicants from all over the globe. And so the requirement was that they would spend 5 hours with us a week in a virtual capacity, whether it be joining our lab meeting, our think tank sessions where we review articles and projects, or they can assist with any virtual activities that we had ongoing. And it was such a large success that Isabella Marcel-Roch actually joined us. She moved from Brazil and is now a PhD student with me. So we think the first year was quite successful. And last year we had Indianara from Brazil who also joined for a full year. And so this is a fabulous opportunity for students across the globe to become involved in our research in a virtual capacity. They have been significant and made substantial contributions to publications and insight regarding best practices for research. And so we have not yet posted for this year because we are currently reevaluating how we continue to do this. We have moved a lot of our activities back on site, but also the changes in some of the IT policies have made this one of our largest challenges without some of the access to VPN and others. So we're just thinking about what the best strategy will be moving forward to offer the same type of quality and access for students that join us. But we have had sometimes over 50 applicants for these postings across students who are already fully engaged in PhD programs elsewhere. And so we think it's a huge plus for the program, and we're just thinking about best ways to move forward. Here by thanking the team that I get to work with every day. I was an N of 1 about 10 years ago, and so we are an N of 15 in our research program. The faces have changed over the years, which is expected and hoped for. Students graduate and move on, but you can see a few of the friendly faces that we've had over the years. And I'm going to say the biggest thanks goes to my 2 small children that I've also had during the past decade. My husband didn't want to be featured. Actually, I didn't ask him because I thought he might say no. But I posted my 2 children, mes 2 enfants, Noël et Claire, sont là. So with that, I will say thank you, and hopefully a few points to take home with you from the talk this afternoon.
Thank you. That's fantastic. Yeah, so we're recruiting those 2. Yeah, and so it's a great presentation. I think it's a great illustration of having a really passionate sort of quest for answers, right? And I think your talent in terms of being able to conduct randomized trials in this field, which is really lacking, and then being able to then get a funding for it. But don't give it the Serbia example too often, because that doesn't happen.
No, it doesn't. No, it doesn't. It's a bit of a unicorn.
And but it's really actually, putting a compelling case together, for funding, and then do the right study and then publish afterwards. So it's really, really, really exciting. And so, are there questions from the house here? Maybe. So there are questions online. So I'll post those, and I have questions as well. So Jim Roberty says just a fantastic presentation. So I think it was just a really endorsement, I think, a lot of our sentiments. And so he had a question that is that if you are actually trying to perform, let's say, HIT type of a training, and but the patient, let's say, is on a beta blocker, and how do you adjust in terms of the heart rate effect from the medication?
Yeah, that's a great question, and one that we've put a lot of thought into over the years with our trials. So I reported the heart rate data within the figures in our JAMA Network open publication because it was a way to at least compare the exercise training programs between our standard cardiac rehab program and our own in-house exercise training sessions. But what we typically do for patients with atrial fibrillation and what we do within our own research program and this upcoming trial is we usually focus on workload. And so our exercise training programs are done on a cyclic ergometer given the unreliability of heart rate during exercise training sessions. And so by prescribing and monitoring workload, we can at least have a standard for comparison for our program and others. But we, of course, collect the heart rate data and report it just so we can be clear in terms of what they may experience with regards to heart rate or palpitations during the exercise training sessions.
Yeah, so very practical and important from a methodology point of view. And just another congratulatory note from Stephanie Prince Ware.
Okay.
That's great. Yeah.
One of my long-standing collaborators.
Yeah. And so I guess maybe I can, I have a couple of questions, and they're very relevant for your presentation. So one thing is that, looking at the HIT versus MIC type of training, when you actually do a deeper dive, that from a couple of the studies actually shows that there are some differences, but may not be overall. But it does show, for example, you had the example of anxiety levels, seem to be different between male and female participants, and the HIT that appears to be better for oxygen consumption changes, probably kind of predictable. And so my question is that could this in fact be an opportunity down the road to tailor the treatment to the preference or sort of certain characteristic of the patient, rather than right now we kind of use pre-assigned groups as part of a study, but down the road, especially when we're thinking about precision medicine and also bedside care, that ways in which we can actually tailor the treatment preferences of the patient or the response. And since there are options available, be maybe even, sort of more like the future way of actually assigning these.
Yeah, that's a great point, Peter. So a lot of these trials, the primary endpoint tends to be VO2 peak, cardiorespiratory fitness, because it's a hard outcome. It's an exercise intervention. So reviewers are going to be looking for a primary outcome, which is VO2 peak. It needs to be measured. It's our gold standard. And we know that it has a very strong and significant relationship with morbidity and mortality. So it tends to be that primary outcome across all trials. And so we include it because we should, but we certainly want to move beyond that. And I think that's some of the strengths that we have done over the last few years of going beyond just the VO2 peak outcome. And so the co-primary outcome of looking at quality of life, which often difficult to stand alone given self-report, but including quality of life. And we certainly have partnered with some of our exercise psychology colleagues and looking at anxiety and looking at mental health, but then also some of the drivers for exercise behavior. And so I didn't get into that with our women's trial, but there is a whole section of the grant that is looking at the exercise psychology. And so we get into the motivators and the barriers and some very specific exercise psychology constructs to measure, because we need to understand what may be helping or hindering individuals from engaging in HIT or engaging in mice. And so that deeper dive into the exercise psychology piece will certainly help us tailor the programs accordingly, but also to identify profiles. And I think we saw just the beginning of that with the differences in anxiety outcomes with males versus females in our sex differences trial, that was surprising that males would benefit more from an anxiety point of view for MIT or mice and females would benefit more so with HIT. And so we're seeing a difference. It's one trial, but the beginning of we really need to understand what it is. And there's certain sex and gender elements there that prior studies have simply not conducted.
Maybe I can take a liberty of asking the last question. There's just a couple of comments. I think they are more complimentary rather than specific questions. And so, lovely. Yeah, so what's your presentation going to be 10 years like that? So my question actually refers to the comments you made earlier, and that is that about female participation in trials. So currently we're doing a big literature review on kind of from clinical trials and recruitment in terms of underrepresented populations, not just women, but, so ethnic minorities, and trying to actually understand but from your point of view, from your experience, what would be needed to actually encourage more women, to participate in trials? Because it's not necessary for lack of trying, because there are several programs, designed for that, but it's still a challenge depending on the population.
I didn't share with you just for timing wise, but so two things. One is, yes, certainly we've experienced our own struggles. We have spent a lot of effort trying to recruit an equal number of women in a lot of our RCTs. And I think that despite the advertisement of trials, whether online, in print, I've done some features and on television before, but the key piece is that it's the barriers. So we can continue to inform patients that we have these trials and encourage them. But if we don't address the barriers that are limiting them from actually participating, I think that's the key piece. So a few years ago in European Preventive Cardiology, we published this lovely little circle figure that shows the barriers from an individual to an environmental level. And so, women often, I'm a perfect example, may have younger children, or children that require attention before and after school, or they may be caring for grandparents, or other ones that require attention. So unless we can really think through all the barriers and offer solutions, so free parking, I think our virtual trial with our women, although we've had lower recruitment just because of the pandemic, but we're bringing the intervention directly to them. And so we're bringing a live session. We're monitoring live for safety reasons. We are adding the communication piece, that the social aspect that they really yearn for. So I think we need to really look at the barriers and bring an intervention that's going to address the barriers. Otherwise, we will continue to advocate, but I don't think we'll see a shift in the numbers. We can't just continue to beat a dead horse, perhaps not the right expression, but that's what we're doing is, like I said, you pull the same script from every publication, it's boilerplate. And so that's really my suggestion, is we really need to attack the barriers.
Yeah, that's so well put, because we really need to put the action, right, to the solution. Yeah. And so just like to take this this moment to thank Jennifer again, for a fantastic presentation, tremendous research momentum as illustrated. And this is just the beginning. And with so many grants and trials still on the way, definitely, look forward to not just 10 years, but next year, for fantastic progress. And then we promise we will actually pay for that parking ticket.
Yes. Will I still look as young in 10 years? I don't know.
So happy New Year to everybody. Thanks for attending.
Thank you so much for attending.